Systemic mastocytosis treatments are really evolving, at the current time after a long period, I would say, of really not a lot of drug development in this space. So just to take a step back and kind of cover the topic sort of holistically, treatments for systemic mastocytosis are either anti-mediator therapies, which continue to play an important role, or cytotoxic agents, and now the targeted therapies, which is kind of a new era that we are in. So all patients, regardless of whether they have indolent, smoldering, or advanced systemic mastocytosis, are going to need some anti-mediator therapies. These are antihistamines, mast cell stabilizers, and many other classes of drugs, which are not felt to be disease modifying, but they are really there to control symptoms and help patients have a better quality of life. Now, moving into some of the cytotoxic agents that have been used over the years, there's things like cladribine, interferon has been used, albeit not very commonly. But then in the last 5 years or so, we've gotten into the era of the KIT inhibitors. And midostaurin was the first one approved in 2017. This is a multi-kinase inhibitor, one of whose targets is KIT, including the KIT D816V mutation, which really underlies the vast majority of cases of systemic mastocytosis. So midostaurin is certainly an active drug. It's been around for a little over 5 years now. But what we've really seen happen in the last couple of years is the development and approval of much more targeted and more potent agents. So Avapritinib would be the poster child of that. This got approved in 2021, June, for advanced systemic mastocytosis, and now this year in May 2023 for indolent systemic mastocytosis at very different doses, but it is now an approved option for most patients with systemic mastocytosis. And what sets this drug apart is that it's really highly potent and extremely selective for the mutant KIT. So with a relative lack of off-target toxicity, some of which you see with midostaurin, for example. Midostaurin inhibits FLT3 and gives you a lot of GI toxicity, for example. Now, Avapritinib does also have some of its own toxicities. At the high doses, there's been some concerns about cognitive adverse events and intracranial bleeding in patients with severe thrombocytopenia, so we do not use it in patients with less than 50,000 platelets. But it's a profoundly active drug in terms of both clinical response rates as well as reduction in the markers of disease burden, which are usually things like spleen volume, tryptase, the KIT allele burden, the D816V allele burden, and the bone marrow mast cell percentage. So all of these, and we now have long follow-up from the first Avapritinib trial, Explorer, in advanced systemic mastocytosis, and we are seeing 4-year survival median in patients with SM with an associated hematologic neoplasm, the most common form of advanced SM, and also in advanced SM as a whole. But again, the majority of the patients with advanced SM are people with SMAHN, and so a significant prolongation of survival there from what would have been expected. Now again, most recently this drug has been approved for indolent disease at a much lower dose, 25 milligrams a day, where it helps patients in terms of symptoms and can be added on to the anti-mediator drugs they're on. And in this dose, at this dose and in this indication, it really has a very clean safety profile. So that's been a great advance. And finally, I'll close with Bezuclastinib, which is another potent and highly selective inhibitor of mutant KIT, actually more selective than Avapritinib, and also does not cross the blood-brain barrier or does so only minimally. So this should avoid the some of the toxicities of Avapritinib, such as cognitive toxicities, as well as that intracranial bleeding I referred to at the high doses, which Bezuclastinib should avoid by virtue of not getting into the blood-brain, into the central nervous system, and also sparing other other kinases like PDGFR. Now with this drug, we have very early results. So again, at this point, with results in just 16 patients, looking highly promising, very similar response rates to Avapritinib, very clean toxicity profile, although again very early. This drug is also being studied in indolent disease, so both advanced and indolent, and smoldering also actually. We do not have results in the public domain yet in the indolent or smoldering setting, only the advanced setting.